So this one. Oh, yeah, okay. So obviously, I'll skip this. The outcome of critical PS, pulmonary arteries and text septum, did improve over time, and I mentioned many of you options, and Dr. Tawfiq also mentioned the importance of the tricuspid valve annulus -2 or -3. And obviously, if we go below -3, we go for single ventricular option. I'll start with this case, 2 days old female. I was wondering at your series, because you had 50-50, because most of the series there are more girls than boys. Cyanosis, PGE, critical pulmonary valve stenosis was established, and successful balloon dilatation. And then you jumped in, you said some of them don't really improve, which is true. So what to do? So Mazini Alwi, he proposed the option that in the intermediate case, we should immediately do a stent. And we argued together about this because Mazini Alwi is quite experienced, and we know interventional cardiology has something to do with hands-on many cases. But if you do like 5 to 10 stenting of the duct per year, you're not good at it. But if you do 60, 70, I would go with Mazini Alwi. Other centers, I didn't think they should go for that. Anyway, baby remained 4 days, still ventilated, and now we start the argument which are all over the place, and Dr. Tawfiq mentioned it. Should we do BT shunt? Should we put a stent? What to do exactly? So we know that this is a dilemma. Some of the babies with critical pulmonary valve stenosis, despite of successful balloon dilatation, remain desaturation. And I show you in our series, it was about 73%. What is generally done? This nice overview from Texas Heart Institute and 2012. And it said, exactly like Dr. Fig mentioned in his paper, that many centers would wait 1 to 2 weeks and then go to the next step, maybe be observed as long as 4 to 6 weeks, and occasionally they even go home on oxygen. And now I have to confuse you because I have to jump back in time and make you understand why we went this idea with alpha blocker and Captopril. Now, it started actually something completely different. We wanted to study alpha blocker and beta blocker in children with pulmonary valve stenosis before and after balloon dilatation. We did it. And we, as a control, we took 15 patients with small PDAs, no shunts almost, before and after closure. And this is what we found out. This is the alpha blocker. We couldn't understand that the alpha receptors in patients with pulmonary valve stenosis were higher than the controls. And as a matter of fact, also another issue which we couldn't understand, it dropped 10 minutes after balloon dilatation. Because usually alpha receptors don't react to stress like beta receptors. Beta receptors, they react fast, and in this case, actually, they increase after balloon dilatation. But we did not expect this to happen, and we could not understand. But we published that, and we said this happens after balloon dilatation. We also studied at that time the many other congenital heart disease, alpha receptors, relation to beta receptors, and we discovered that there is a difference between cyanotic babies, tetralogy, and acyanotic babies. And that the alpha adrenoceptors in cyanosis is 81% higher than those who have normal saturations. And actually there was a negative, significant correlation between receptor density and oxygen saturation. I put it here in a crooked way, but you see when you have saturation 50%, expect the alpha receptors to be high, and if saturation almost 90%, alpha receptors will be on the normal side. Still confusing, we couldn't understand, but we still published because it was never said before that this exists. We know also, this from another study we did in sheep, that hypoxia does cause pulmonary hypertension. Everybody knows that, but we just did this on the sheep for a different reason. Now, the summary of the study showed pulmonary valve stenosis have elevated alpha receptors. They drop after balloon. Hypoxia causes high alpha receptors, and hypoxia, we know, leads some elevation of pulmonary pressure or resistance. Now, we published that, and 2 years later, 2 babies came in a row, like within 1 month difference, and the one was dying actually after balloon dilatation, on beta blockade, on fluid intake and so on, but they didn't. So it occurred to me, what happens if these babies, the alpha receptors remain high because of the hypoxia, and what if we give alpha blockers? So we did. And you wouldn't believe that, but actually the intensivists who I had to convince, because we're giving something new, we were dancing in the ICU because within half an hour, the baby who was dying was now on the verge to survive. Blood gas, saturation, everything was improving. Now it was easier to convince him the next baby who came, so what easier to say, let's start earlier, not wait 2 days. The minute his desaturation getting worse, we'll give it. Improved. And we published that 1999. Of course, it's a new therapy, so it's very difficult to convince people of an observation. At the end, it isn't just an observation. So we thought the following could happen, that we have severe stenosis and hypoxia, both must rise the alpha receptors. If we give alpha blockade, possibly the situation can improve by improving the compliance of the right ventricle. So that's why we gave it. In 2 babies, it worked dramatically, so we were encouraged. But of course, critical PS is not very common. Now, this happened. I was out of town years later, and of course, nobody believed in this therapy, that it is an option. And when I came back, there was this baby 2 weeks after balloon valvuloplasty, and the colleagues were arguing, what should we do next? At that time, stenting was not so common, so obviously bleloc section. So I told them, give me a chance. And we gave alpha blocker. 2 days later, PGE was stopped. And here I had it's a leap jump, if you want, because I said, how do I know if I stop alpha blocker that the patient remains stable? Possibly he will go back into whatever he was before. So I said, I need something oral. And I came, why not give Captopril? Captopril also leads to vasodilatation, but on different mechanism. On the other, but we had to be careful because we know in neonates Captopril can be dangerous for the kidney. The neonatologists, they have an equation. They don't give what we give in children. They give lower dose, 0.15 milligram per kg per day. And this is what we did. And this is what happened. We give Captopril, discharge the baby on Captopril, and he was doing fine in the clinic. And because people were arguing, what about the blood pressure? So I did this curve in this baby, and you see here, mean blood pressure, respiratory rate, heart rate. Days on phentolamine, PGE here was stopped, and Captopril was given here. So you agree with me, the main blood pressure remained stable. Though we gave 2 medications which actually lower the blood pressure. So we were happy that obviously our dosage are fine with the babies and well tolerated. Now, another few years passed, and we had a baby. We did balloon dilatation, went very nice and fine, but there was understanding between us and the NICU people. The baby was actually extubated, was not ventilated. We do slightly different from what the colleague said. If the baby is stable, we try not to ventilate them electively, but to do almost unconscious sedation. So what they did, when they came to NICU, they stopped prostaglandin. So he remained oxygen dependent. So I said, why not give Captopril from the start? This is what we did here. And what happened is this. that within 12 hours, we could stop oxygen completely. And you agree with me, very clear saturation, and here the oxygen requirement stopped by 21% room air. So we knew, so Captopril also alone could be an option as long as you keep the dose low. Because if you go high, you might have other issues. Now, just a reminder here, I'll skip through this. Dr. Tawfiq mentioned that it's critical PS is a big thing. You have a severe TR, you have a PFO with the right to left shunt, and a PDA. So you're dealing really with more complex issues and not just pulmonary valve stenosis. In brief, our experience, 28 patients had this disease, and after balloon valvuloplasty, 71%, so 20 patients, remained desaturated, where we had to argue what to do next. And those patients, we gave either phentolamine or Captopril. Their mean age, mean weight, and as I mentioned, and here 18 were newborn, and 2 were so-called what we call late presenter, those who are 3 months, 5 months, peripheral hospital, and they come really in severe congestive heart failure. We added to the group. Of course, they didn't have a duct anymore, but they were right-sided failure. Saturation means was here. PDA, as I said, 18 had a PDA, right to left shunt in all or bidirectional. The mean pulmonary stenosis gradient was 75 millimeter mercury. Cath data, as I mentioned, this is the gradient. We measured actually by Doppler, because in many patients, we just go in the PA balloon dilate without measuring the gradient, because we have the Doppler gradient by echo, and the echo, as Dr. Tawfiq mentioned, is much better analyzing the annulus of the PA, much better than an angio. So the gradient dropped significantly, but watch here, the oxygen saturation didn't change significantly in the 20 patients. I took aside these 8 other patients. Now, phentolamine, 8 out of 9 improved on phentolamine. 1 did not, and we discovered why. This patient had a significant infundibular stenosis. And I also, before, I always believed when we have this, that the right ventricle, I don't know the word for it, when it crashes after balloon dilatation, I thought always is a suicidal right ventricle, it's always an infundibular stenosis. It turned out to be, it's not true. What happens actually that you have a right ventricle of very poor compliance, and it has been described in the literature. And infundibular stenosis you'll find very rarely in this condition. In adult patient, you might have severe infundibular stenosis. In this patient, for me, at least my experience, is not the case. Now, this patient does not respond at all to phentolamine. And he had a gradient 56. Electively, we waited, and then we sent him for surgery. 11 newborn, they were more stable. So we put them immediately on Captopril, oral Captopril, and they did improve. Now, there was a difference how fast they did improve. Phentolamine, quite fast. And I told you the one case, we danced. So it must be really not very long, because we stopped also very fast to dance. In like half an hour, you could see things happening. Phentolamine. Captopril needs more, like double as much time. Mean duration hospital stay here like 3 days, and here 5 days. Everybody who was on phentolamine was switched on oral Captopril, sent home on Captopril as well. And follow-up after 23 months, all did well. Captopril was stopped whenever the PFO was shunting, either not shunting right to left or was closed, we stopped it, of course, along with the oxygen saturation. We managed to publish this actually, like last week, I got the message that it was published. It was very difficult to get published, because new things always, you have many people, rightly so, asking why this, why that. Conclusion, elevated alpha adrenoceptors dropped after balloon valvuloplasty PS. In critical PS, alpha receptors possibly remain elevated. This could be due to associated hypoxia and poor RV compliance. Alpha blocker lead to vasodilation, systemic and pulmonary vasculature. They may improve RV compliance as well. This is what I really believe. that alpha blockers seem also to improve the compliance of the right ventricle. Otherwise, I cannot understand that it works so fast. Both drugs, Captopril and alpha blocker, were effective in the management of 19 out of 20 newborn with critical pulmonary valve stenosis.